Greetings, Nargiza.
Hello, John.
I'm watching you.
How are you?
Good, how are you?
Yeah, I'm also good. Little bit cold, but otherwise I'm fine.
If you don't like the cold, you're living in the wrong part of the world.
No, I don't like cold. How is
Okay.
everything, John? By the way, can I see you? I'm not able to see you.
Hold on. Let me get my camera working.
Mm-hmm.
You
Great.
got a good lineup there today.
What, sorry?
You have a good lineup. You have a good list of speakers.
Yes, John. And by the way, 17th of December will be our last webinar in this
Okay.
year. Okay.
Okay.
So let's do it at 3 p.m. Okay. We will do it later on. We will go on video chat. But I just want to tell that let it be 3 p.m. because I'm calling James Liu and he just accepted in the morning.
Okay.
So he's from New Jersey, right? What time is in
Well,
New Jersey?
make sure I don't forget that. So you want me to change the time schedule? Is it scheduled already or no?
Yeah, I think we scheduled it till
Yeah,
last
we'll
time.
talk after. We'll talk after.
Yeah, we will talk. I'm just telling that James Liu will be coming,
Oh,
and
James Leo? Oh, good, good,
yeah,
good.
that's why I called him. So that will be
Well,
you.
you can get anybody. You can really get anybody
Mm-hmm.
because some people just like to speak, and some people like James, he loves to present.
Mm-hmm.
I didn't even mention him. I should have mentioned him. But I'm finding maybe the same thing in Russia. I'm finding in English, it's good for me as far as an organizer to have a series, to have
Mm-hmm.
someone do a series on trauma or a series on pediatrics.
I'm trying to get
As
one.
well as the regular ones like now.
Yeah, John, I'm getting you. Uh, I'm trying my best to find the institute and someone enthusiastic person who will be ready for that. I almost
Yeah,
found, but this man is disappeared. I know when. Maybe he one day he will appear it
it's
again, but
okay.
then let's see.
You got to get people when they're hot, when they want to do it,
Yeah.
uh, because it's hard to bother someone so that they do it. If they want to do it, they'll do it, and they'll seek you out. Like Atul Goel, he loves to broadcast.
Mm-hmm.
He loves to,
Yes, John. He loves to.
and he'll.
But
Okay, okay. So, let's see. Yeah,
yeah,
yeah.
John, I
How?
wanted to ask how is your funding is going on? Does anyone gives you something there, no?
I'm sorry.
How is your funding? Is
I haven't
somebody
really started pushing it yet. I've got to start pushing it and bring it to the fore. But
hmm
it's there. It's there. I just wanted to set it up. Uh, we have a big conference in Yemen next week at Wednesday and Thursday this week,
hmm
and that is definitely a third world country, and we've broadcast them for the third year for free.
hmm
And I may mention that in front of Lawton because Lawton's speaking. I
hmm
might say, Dr. Lawton, by the way, you know that we say accept contributions. Put
We
them
can
on the spot.
we can work through the I don't know some societies. So let's see.
Whatever.
hmm
Okay, I'll be back. Okay, I gotta do some
Yes,
things.
yes, yes, John. I also will be back.
Did you just call me?
John, can you make me co-host, please, so that if people comes, I can. We have
Yeah.
to add Professor Judy Portiban as a panelist.
I haven't seen him for a while. How you been, Nargiza? Busy, busy, of course.
Yeah, a little bit busy still because I'm talking to Professor Ipe. He's in Cambodia right now.
Oh,
So,
okay. Hello, Jerry. How you doing?
Hi,
good afternoon, Professor.
John.
I
Hello.
haven't
Hi,
seen,
Nargiza. How
I
are
haven't
you?
seen you. I haven't seen you
Good,
for a
thank you.
while.
Yes, for some time.
Yeah, how you? I see you've been active.
I think we should meet often. Yes, right. Sure. How are
Yeah.
you?
Good, good.
Busy as usual, right?
Things are slowing down a little bit for the
Yeah.
Christmas days. You know, I tried going full blast last year, but it just wasn't worth it because a lot of people just don't want to go online
Ah,
over Christmas. That's my impression anyway.
yeah. I know, but I keep following your webinars and a lot being conducted and it's very well.
Yes, yes. Well, we're having people like Nargiza help me organize the webinars because it saves me work. It saves me, you know, they did the footwork is getting to people, arranging the times, and it's good to have help. Right, Nargiza?
Yes.
Nargisa is now doing very well. She is able to get so many people as faculties, and that's very good. And
Thank you, sir.
that makes sense also because people like to be a panelist and wanted to exchange their views, experience, and in fact that it covers quite a lot of places. Um, the For example, now this meeting will be covering a large amount in the area of Russia, Uzbekistan, and other areas. And so when you conduct at different faculties, different places, it certainly will be of very much. You're doing good job.
Yes, thank you. I'm trying my best, as I told before, to find one experienced neurosurgeon and one young neurosurgeon. So for everyone, it will be interesting. And I just want to show that no need to be scared of presenting something. And young people are every time welcome. And we have to get experience from you. We have to tell something and get your, good
Yeah,
complaints
it's
and something.
it's always a nice thing to particularly when you give talks to the younger generation and who are in the beginning of their career, and also the young neurosurgeons, right?
Yes,
Uh,
sir.
many like to know things how it's being done in different areas, different places, and by different people. So it always make lot of sense. I really appreciate you because I saw you have chosen 5 speakers. It's a good thing. Yeah.
Let's hope. Sometimes it doesn't work every time. Somebody can cancel just before few hours, but that's okay. It happens. I mean, all these
That's fair
issues,
enough.
we just have to know how to handle them. But otherwise, if at least we will get few attendance, few speakers, then I think neurosurgical webinars are not supposed to have around 1,000 or 2,000 people. It's very difficult and narrow area.
Yeah.
And not everyone in this area are feeling themselves quite comfortable. So yes,
Yeah.
and the speakers are high level, so
But
it
that's
requires time to understand.
good. See, basically, who are interested will join,
Yes.
and the numbers may not be large numbers. Even if it is small numbers and that is going to be benefited, that's good.
Yes.
That's one thing. Yes, that's one thing extremely uh, important thing. Even and in India also they do a lot of webinars um, at the level at the country level. There are always good crowd. Somebody is there. Even if it is 100 neurosurgeons join, it's benefit them. And then the postgraduates also join. So it makes a lot of sense because so many different type of meetings are happening because subdivisions are very high in neurosurgery. So I'm sure that this will be of benefit to many people. Well, what time we are starting at exactly? Right time we'll be starting.
We're supposed to start after 4 minutes, but I'm waiting. There are just 6
Yeah, yeah.
participants. Usually they
Yeah,
come faster.
Yeah, we start a little late sometimes,
Okay, Bulat.
later.
John, the first speaker has.
The first speaker is Rinat Nurmukhamedov. So I'm waiting when he joins.
Yeah. We'll wait for, I think.
Yeah, Manuel is there.
Hello, everyone.
Hi, everyone. Hi, Bulat.
Hello.
Will we be able to see you, Bulat, today? To see your face. One second.
Oh, Manuel's here. Oh, is Manuel speaking? He's not speaking, is he?
Hello, John. How are you?
Emmanuel, how you doing?
More or less. I got sick.
Oh, okay.
Yeah, winter. In behalf
Oh,
of Renato Mohamedo, I'm gonna make his presentation because he wasn't able to come because he have some emergency patient today.
okay.
Okay, so Manuel, you will be presenting, right?
Yeah.
Okay. We will start in few minutes, I think in 2 minutes.
Yeah, perfect.
Yeah. You can.
Manuel, have you met Jody yet?
Sorry?
Manuel, have you met Jody Parthaban? A big
I
back
think we
neurosurgeon.
meet in several Zoom.
Okay, your pictures, your camera's not on. Neither is mine.
No, remember my camera doesn't work since a long time ago.
Oh, okay.
You remember we have this conversation.
Well, as long as you can,
if I use a computer,
as long as the camera, you can see the gym from your. As long as the camera can see the gym from your apartment. You right, Manuel?
Yeah.
Yeah, you showed me the camera that looks at the gym.
No. Today no gym. I got sick. I have fever and coughing.
Oh, okay. Okay, you want to wait a few minutes, Nargiza? Let's wait a couple minutes, okay?
We can start or we can wait, whatever you want.
Yeah, just a couple of minutes. That's all.
Okay.
I am ready, John.
People will Okay, we can start if we have the
One
speakers here.
second, 1 second. I will just
Okay.
need one more panelist. 1 second. Mario is there.
Sure.
Мгм. Так, 1 second.
It's good to see some Russians here. Yeah, we might as well start. Okay, Nargisa? You ready, Nargisa? Hello?
Ready. I'm just waiting for our one more speaker, Dr. Mario Ganov. Okay, let's start. Let's start.
Okay. 10, 9, 8,
okay,
7, 6. Oh, wait a minute. Hold on. Let me make sure I got I got the stream on. Okay, 10, 9, 8. I'm sorry. Hello, how you doing? Welcome. We're starting in a minute.
Hello.
10. Ready? Nuggies 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from home of Neurosurgical TV, Miami Beach. Today we have another Russian Neurosurgery Grand Rounds, chaired by Nargiza Sartova. And this is approximately, we've had a lot of Russian Neurosurgery Grand Rounds. And okay, you need to mute there, okay? I'll get you. Anyways, Nargiza Sartova, a neurosurgeon from Uzbekistan, is put together this whole webcast, and we appreciate that. Welcome, Nargiza.
Hello, everyone. Welcome to our sixth webinar, Russian Neurosurgery Grand Rounds. It's a great opportunity to be here today with all of you. And let's start our webinar from our first speaker. On behalf of Dr. Rinat Nurmagomedov, who is MD, PhD neurosurgeon from Moscow, head of the spinal department of Central Clinical Hospital of Russian Academic Sciences. Today, Dr. Emmanuel Encarnacion will be talking about transforaminal lumbar interbody fusion versus Wilst leaf in the treatment of single-level lumbar spondylolisthesis retrospective study on 600 patients. Please, Manuel, you are welcome.
Yeah, thank you. Thank you so much, Nargisa, John. As Nargisa said, in behalf of Dr. Renat Nurmagomedov, I'm going to make his presentation today. Okay, please, can you tell me if all of you see my screen?
Yes, we can see it. Make just
Yeah,
presentation.
It's not
Okay,
presentation. You need to put it on presentation mode, Manuel.
Yeah. Do you see it?
It's not on presentation mode. You have on the
But
bottom.
are you seeing it?
Yes,
Yeah, we
but
can
not
see
but
it.
not
Yes,
on
we can see it.
presentation mode. Go to the bottom of the screen at the right, and you need to put it on presentation mode.
Okay.
You know what I mean? At the bottom.
Okay, now.
There you go. Perfect. Perfect.
Yeah, perfect. Okay. Thank you so much, John. Yeah, okay, we'll start. Yeah, so as all of you know, the transforaminal lumbar interbody fusion, TLIF, it's a well-known procedure for the spine surgery from a lot of spine pathology. Sometimes, for example, with the spondylolisthesis in stage 1, 2, or 3, it's very, very common to use it. It's also some spondylitis. So what we want to show, of course, as everybody here know, we have the open TLIF and we have the Wilson TLIF. Okay, but what's the difference between both of them? The main difference of both of them, we're gonna see it here step by step. Okay, so the method we use for this study was a retrospective study. We include 600 patients with the single level spondylolisthesis. Okay, yeah, maybe you can ask, why a single level? Yeah, right now, what do the huge amount of patients from the Clinical Hospital of Jerusalem Academy of Science, we decide to take only one single level because in the year easily we can have 2,000, almost 3,000 patients. So the patient were selected based on the specific criteria and the exclusion criteria. We divide into groups. Group A, 300 patient who we performs open TLIF, and group B, patient who we performs the Wilson approach, Wilson TLIF. Okay, our goal. Yeah, of course, we already know there is a big difference between both of these techniques. The Wilson technique is better. We easily can say, yeah, it's more easy to, it's more have a better results, can have a better result for the patient, especially in young patients. But of course, there is some pitfalls in all of them. In all technique, we have some pitfalls. So what we do when we are perform the open TLIF, as we already know, we take our patient, sorry. So we already know we take our patient in the Wilson frame, and then we perform one single middle line, okay? One single middle line, and then we start to dissect through fascia and through muscles. And then we got the superior articular process, and then in this is the enter point. If we divide, I'm gonna make it here. If we divide the superior articular process, yeah, this is superior, lateral, and this is inferior, medial, okay? We need to use our imagination here. And we can divide in three. We put three lines. 1, 2, and 3. So this is our attack point here. This is our attack point. Yeah, sorry. Yeah, this is our attack point. This is the easy method we use for transpedicular fusion. Then we can use, then after we make the decompression, yeah, oh, cannot remove this. After we can make the decompression, then we put our cage, okay? Of course, if we have an extensive amount of different cage all over the market. We have a retractor one, we have the banana cage, we have the bullet cage, and so on. And in the end, as you can see, one single middle line incision, and then we close easily. Yeah, it can be on you if we left the drainage or not. Usually after, if we make a big decompression, 2 levels, yeah, we usually left the drainage. Okay, so in the Wilson TLIF, in the Wilson TLIF approach, we made 2 middle incision lines, okay? Each one of them 2.5 centimeter lateral to the middle line. Then we can use our tubular here, as you can see. You can use any kind of retractor you want. You can use the Caspar, speckle Caspar. You can use the quadrant, for example, or you can use any single tubular set. Then the important and the key part of the Wilson technique is we can make a finger dissection. We can call it like a finger dissection. Why? Because we're going through here. Remember, we make two middle line here, 1 and 2, okay? And then we're going dissecting. We're going dissecting with the finger. All right, there goes this. Yeah, so, yeah, sorry. Oh, we have here the muscles, multifidus paraspinalis here, and with the finger, we can go through these fibers. Only with the finger, and then we will touch this protuberance, this superior articular process, and then, of course, we're gonna make the edge ray. What's the big difference between both techniques is the use of the edge ray. Of course, in the Wilson technique, because we can say more blind, we use more edge ray. You can see here about the preparation of the patient. Yeah, of course. One of the big problems sometimes is in which patient we're gonna make it, because yeah, you can say I want to give this minimal invasive procedure to all my patients, but of course not. This is not panacea. We need to know when we're gonna use it, because in patient with the very fat patient, it's not so good. No, it's not good to use the Wilson technique. In this fat patient, we perform the open cliff. You can see not too much flexion, okay, not too much extension. It's a key point. And of course, the main point is you need to be first before being a surgeon, you need to be a good X-ray technician. Yeah, because if you don't know what you're looking for, with the proper X-ray, it's gonna be more hard for you know what you're gonna operate. You can see here. Yeah. So you can see here, to middle line, okay? This is the middle line here, 2.5 centimeter one. This one is medial to the superior articular process, and this is lateral to the superior articular process. So it means this is the entry point of the superior articular process. This is our entry point for the pedicular screw. You can see here. So you see here, okay? Our first X-ray. We mark our pedicle here. Lateral and middle to the pedicle. X-ray, okay? Remember, between multifidus and longissimus, okay? This is our entry point. This is our dissection. For that, this is our key. You can see here, your finger become a key to enter there in this area. So between the split and the longest muscles, there are many perforating vessels that pass through the muscles membrane from the muscle gap and pass along the surface of the muscle membrane. These vessels can be used to guide and finding our muscles guide, the gap, this area when they are divided. Okay. Okay, so when we are pressing the fascia in the longitudinal direction with the blunt periosteal dissector, this is important. And then the perceived failure of can lead us into the intermuscular space. You can see here, finger dissection is very important. You can see here, yeah, perfect. You see, finger dissection. This is the time, and this is the oxymoron when we can say you are watching with the finger. So later when we have our pedicles, then our pedicle screw, then the tubular retractor is placed in the decompression area. We can use the dissector or the needle to support or to have more accurate the area of we're gonna make the decompression. Okay. Again here, to always remind, finger dissection to here. We're gonna fill this bulb. Okay. Again. So what we do here, we are marking, remember we put the screw in this part and we were put the screw here and we're making this compression in this side. You can see this is the view you will see through the decompression area. As I said before, if you don't have the tubular set, you can use easily the Caspar. You can have a very good result anyway. Of course, there is pitfalls in both of them. The long learning curve in the, we'll say, of course, is bigger than the open TLIF radiation exposure. The equipment, because if you don't have the proper equipment, it's gonna be more hard for you. If you don't have a tubular set, the microscope, or you don't have the Caspar set, the speckle Caspar. Okay, the placement precision can be inadequate for the decompression. Okay, it's more easy to make the nerve root the nerve root are in risk, okay, in this kind of technique more than in the open TLIF. Of course, what Dr. Nur Mohamedov create this kind of cage. This is a 3D printing cage, specially designed for each patient. The idea is we can use our own cage depending on the necessity of the own patient. So you can see here, the cage in this part, as you can see here, is gonna grab better to don't gonna migrate in the interbody space. Here is the attached part, and there is a follow-up of a future study we are performing to see how is the use of this special cage with design, and how is the result if the patient benefits more in one cage with this especially designed for them or in the generic cage. Till now, we don't have any kind of migration in this case. You can see here. This is the our story. You can check it. So also for this kind of wheelchair technique, and also for the for the open TLIF, we create this half tubular retractor. The idea is, as you can see here, the idea is you can it can be attached as a chair in the transverse and the transverse process, and it's gonna hug the superior process. In this way, we can guide directly our pedicular screw in this area, and we're gonna protect more the muscles. This is you can see here. This is the way it look like. You can see here again. So this retractor, using this kind of retractor, it's a self-made 3D printed retractor. This is our patent. So, and our result you can see here. You can see here the number of patients. Of course, you can see the time of the surgery. You can see in the wheelchair technique, it can be even more fast than in the open TLIF. Of course, the time of the fluoroscopy, you can see, is going to be higher in the wheelchair technique and is lower in the open TLIF. The blood loss, as you can see, in the open TLIF is bigger than in the wheelchair TLIF. So our conclusion, this retrospective observational cohort study aimed to compare the clinical result and the surgical characteristic between the wheelchair minimally invasive TLIF and the conventional open TLIF. The length of the hospital stay for the wheelchair group have benefit in terms of reducing the time of the hospitalization in the patient. So it can be reflect in the patient go back to this work for more fast than in the open TLIF. And again, we use this in measuring degree 1 or 2 lumbar spondylolisthesis or lumbar instability. We find both techniques result in similar outcome in measuring degree. Spondylolisthesis 1 or 2 have the same result. Remember this phrase, I like it so very much. One day when we are not here, we will be what we have done and in the way we change other people's life. Thank you.
Thank you very much, Manuel, for your interesting presentation. If anybody has questions or comments from the audience. We have one question from Muhammad Shaib. Can wheels be done by having midline and going lateral below subcutaneous plane? The question.
Yes. In some places they perform a middle line incision and then they dissect subcutaneously two middle lines, two dissection. But in the way we perform the technique is two middle line, two lines, 2.5 centimeters lateral to the middle line. This is the way we do it. But of course, remember, all the road take you to the room. The important is the good result of the patient. Yeah, you can make a middle line, and then you can make the wheelchair with the middle line.
Okay, thank you. Any other questions or comments?
Nargis, if you allow me, the only comment that I wanted to make regarding this last question is
Yes.
that the importance of a midline incision is remarkable, particularly for revision cases. If you need to extend, obviously you want to be allowed to make a longer incision and not to be fully on the muscle. So if you can do on the midline, potentially this might allow for a longer skin incision, easier retraction of the muscle in revision cases.
Thank you, Dr. Mario, for your comment. Okay, we can move to our second speaker, right? Let me introduce our second international speaker, Dr. Jyoti Parthiban, MD, MCH. Dr. Parthiban is a senior consultant neurosurgeon with expertise in microneurosurgery and special interest in spinal surgery in Kowai Medical College and Hospitals in Tamil Nadu, India. Dr. Parthiban is a well-known educator who already published 4 of his books in spinal surgery, and the 5th book is editing right now. He has done public awareness on brain death. He made a contribution in neurotrauma, research papers on stem cell in spinal cord injury, and he is the member of a lot of societies, especially WFNS, course director of National Board Examination in Kowai Medical College and Hospitals. So today, Dr. Parthiban will be talking about surgical techniques, anterior cervical discectomy and fusion. Welcome, sir. Could you unmute yourself, please?
Okay, Dr. Parthiban, can you unmute?
Yeah.
Okay, there you go.
Thank you very much, Dr. Nargis, for inviting me. And John, it's lovely to see you another day.
Thank you.
I'm very happy to talk something about anterior cervical discectomy and fusion. And basically, you know, I have prepared this for the younger generations to have some good knowledge on this particular technique. This is a very common surgery, which is done by the neurosurgeons. And we see a lot of cervical disc prolapses and osteophytes. As we all know that this technique is very simple because we go through the anterior approach and we have beautiful fascias and then a natural pathway to reach the anterior aspect of the vertebral body and the disc space. Right? Till that region, and when we go there, much easier, that we all know about it. But beyond that, many times the young neurosurgeons ask a lot of questions, what to do next. Now, I can show you some of the videos, how I do it, and these are the pins in 2 vertebral bodies. And after the disc is well removed through the anterior approach, the disc should be thoroughly removed systematically. This is an osteophyte here. This is the posterior end of the disc space. There is an osteophyte, posterior osteophyte, and then we have the conglomeration of the disc and also the annulus, which is fibrosed into form the compression. So usually after the pins are placed, and then you make a small distraction so that you can see that these disc space, you know, you can see that the gap which is coming from the first and foremost is that we use a diamond drill. The diamond drill of 5 millimeter or 6 millimeter in size, and the size is slightly bigger. And drill with caution. And microsurgery, the idea of showing the video is that to develop the skills and how you drill in that region. You can see the amount of saline which is coming here, the copious saline, but at the same time a suction on one hand and the drill on the other hand with the microscope. After that, once you reach a little bit close to the PLL, and you always use a curette And if the curate is not sufficient, then you have to go in for a sharp hook. But in this case, you can see here, I'm finding it a bit difficult to get into that. That means that it needs more drilling. Simple that way. So one has to go step by step and slowly and gently. There is no need to hurry up in this region, because any technique which is going to be harsh here is not accepted. So try to do it very gently with the drills, and then we can always after drilling with a bigger size drill here, you can see this is the bigger size diameter drill. And further you go down by step, whatever you see white in color is osteophytes. Whatever you see in slightly yellow in color is not osteophytes. It's a very simple way of identifying, because young surgeons keep asking where is the osteophyte. When you keep drilling, you can find it with your vision and also with your feeling. Now here I have changed the drill to a smaller drill. It's just a smaller drill. So the idea is you go by step. First you go by 5 mm drill, and then make it a smaller one, and then make a further smaller one until you nicely do the drilling gently, completely, if it is a long and very large osteophyte. Sometimes you have osteophyte on one side. And if you have an osteophyte on one side, you drill only on that side. That is good enough. You can see this is a sharp hook here, and try to hook it up, see, and still it is not coming. So that means it is not sufficient. You need drilling further. So this is the way you have to go by steps. No need to hurry up. The important point is this irrigation. This irrigation makes the bone dust to get dissolved, but at the same time it cools. And now here I'm going for a blunt small dissector. I'm still not able to get into the very close to the PLL. So how will you do that now? So that means you have to be very patient. Now slowly I'm getting some more. And once you get this bone and you find the PLL or the soft tissue, that use 1 mm Kerrison punch. Very classical, nothing more than that. Just 1 mm Kerrison punch has to be used to remove the edges of the osteophyte on one side. Usually, it is not that easy to get into that space, so you have to be very careful. Now, when you start seeing this, you find the difference. You can see that now you are able to go underneath. So beautifully, you can go underneath. So you have to drill it out methodically until you reach a soft tissue structure. So after you start removing, you can find this blood, you can see it becomes red. That means that you are coming up. Now you can see this, what I said about is it's a complete, like a pannus. You can see the posterior aspect of the annulus, which is plugged inside along with the degenerative disc, and then you start hooking it out. And no need to do very harsh study, but then keep on hook it out and hook out, and then take out the pieces by pieces. This is very important. And all the time, no force beyond your limitation. So that means most of your work is done at the wrist region. The control of the instrument is at the wrist, not at the shoulder. No shoulder work. And then subsequently, you can also use the same side. That is, the same side means the upcuts on the same side, so that you can take more bones. I like to remove as much as this material, the pannus, and everything until I see the PLL. You can see the disc materials which are coming out here, PLL. And if the PLL is open, is very good, and you can open the PLL and remove the soft disc. Once you remove the PLL, what you see is only soft disc, but you will never get a hard one. The hard one is get over until above the PLL. So this movement you see, what you see here is very comfortable. That means your decompression is good, and you are decompressing well. And this is a osteophyte which is decompressed. Is over? No, it is not over. Then so you keep on doing with this sharp hooks. It is very important, because sometimes we miss some segment of the the disc and also the pannus, whatever we call this pannus and fibrous tissue, we miss it. So better to remove as much as possible and make this one supple. If for some time you can see that they start pulsating. Once you start pulsating, that you're sure that you have decompressed. Whether to remove the complete PLL is out of question. If you're lifting it up, that means that you have done a good decompression. So this is very important in the surgical technical aspect. And this, why I'm showing this is because this is where many young surgeons have no clue. This is the one place where the young surgeons miss it out. Then after your good decompression, you have to do the interbody fusion. See, you can see that, and these are the pins, and there, now I'm doing the measuring. If it is a 5 mm or 6 mm, whatever the size is there, you see that, see how much it is going, and then wait to further augment it. Subsequently, you have to make a bed. This is very important. You have to make a nice bed over the adjacent aspect of the vertebral body. Now, this is very important. The cartilage should not be removed completely. The cartilage must be drilled partially. Don't remove completely, because complete removal can expose the cancerous bone, and then your graft can subside. So now you can see that I have selected a graft so that it can go snugly in. This is when the pins are distracted. That is, you distract it by 2 to 3 millimeters. So if you have about 6 mm of this space, then you can go in for 8 mm. If you have a 5 mm, you can go for 6 mm more. And the impact must be very, very gentle. Do not hammer it. Just impact like that, gently. When you put itself, the graft should go and settle down very nicely. And subsequently, after that, you can always remove your pin. The moment you remove the pin, these two bones will come and snug the graft. It's very important. Once it's snug the graft, this cage will never come out. This is the important art of interbody fusion. This will prevent, and you will never have a graft migration if you do this. That is the three vertebral body. You can see that you use any force, this will not come out. So this is very important. After this one, after showing this interbody fusion, I like to show you, I have to stop share, and then again, I have to go back, and I think I have to go back and get the other one. One more. I'll share this. Are you able to see this?
Yes, we are able to.
Yeah, you're able to see that? Okay.
Yes.
Now, this is what I said, this countersink graft technique. Many young surgeons do not know this. Because of that, they find a lot of graft migration anteriorly. Now, once you start doing this technique, which I showed you, it will never and ever get displaced. So this technique, one should master this technique, and standalone grafts, we can place it. I just like to go forward with my PPT. That is, this is the long years ago. This was taken in 2002, and before that we did in 1992. This is autographs, and this autograft fuses, and there is always a settlement. This is a research we did with autograft and allograft. What I showed you first is the recent techniques. What I'm now showing is what happened those days. And we used allograft and autograft to find out the differences. And we made our own methodology to study the disc settlement. And we realized that the autografts are the best one in the world at present available. Though we use the metal implants are good. They hold it very well, but still the tricortical autograft is extremely good. And this paper, which was published in 2002, was later, very, very later, it was quoted by Jeffrey Wang group in their research with autograft versus allograft. now this is what I showed you, various type of interbody grafts are available now. So surgeons have so much available all over the world, P grafts, titanium grafts, and then they are packed with cancerous bone. So where to get this cancerous bone? We get the cancerous bone from these osteophytes here, these osteophytes, and then these cartilages we can get it, or we have to take from iliac crest. But to go to the iliac crest, we need another operation, and that is not necessary. So after in the recent past, we have all these bone substitutes coming to our help to use it for surgery. Then what else we can do? What is this? Or the standalone ACDF which I have done, and you can see in all these things are the keystone techniques. The keystone technique is extremely good and very effective. You can see how it fuses. It fuses very well, and there is no graft migration. There will be a little bit settlement, but it grows very well. To reduce this settlement and to improve the fusion, surgical techniques have changed to put screws over here. But is that really needed? I doubt. And because of the implants are being promoted in a very high way to maintain the lordosis. Now, and recently, I would like to introduce a technique which we are doing now, a little bit to thought-provoking technique. We do not want to take the cancellous bones from iliac crest, but we realize that there are a lot of bones are available in the vertebral body, which is next to the place where we are doing the anterior cervical discectomy. We never thought about it. And so we plan to excavate a little bit cancerous bone and put it into the interbody cages. So this technique was developed by me in over a period of time. And then we started doing this technique. We call this technique as adjacent cortical cancellous bone grafting technique. And this is the technique which you can have a look at this technique. We take the cancerous bone and then put it back into this graft site. That is where you have already put one cage there. Now, after doing this, we start, you can see all the pictures, you can see these chronological pictures, which shows this empty area we started filling up with the substitutes. This is to augment the fusion. Now, where was the, when we were doing this technique, we never knew that there were already two research articles were published at that period of time. So when we went behind, and then we found that the Pitsen has done one study where they have done an interbody fusion, and then they removed this cancerous bone from here and put it on pressure. They realized there does not appear to be a significant early biomechanical weakening of the adjacent vertebrae that caused aforementioned technique, because whenever we take a little bit cancerous bone, we also always have a fear that a vertebral body will collapse, but it is not so. It will not collapse if you take a limited amount. Another paper also, we saw that it is by water shield. And similarly, they also have done a study, and they found that the local autograft harvested from the adjacent vertebrae reduces the morbidity associated with second surgical site from the iliac crest. But this technique where we take the graft from the body does not make much problem in the contour of the vertebral body. That is their study. All these studies were coming at the time when I was publishing this article in various parts of the world in between 2017, 15, and 14. And these are some of the cases you can see here. This is from here, we take the graft and then place it inside. In March 2017, and this is in April and May. There is a beautiful fusion here, not much of problems. And we did so many cases like this. You can see here another case from March 17 to August 17, very nice fusion. We do not have much change in the lordosis. Lordosis also was very fine. And this is another patient for 1 year follow-up. The fusion is good. You can find the place from where we have taken the graft and place it inside. So what it means, why this study is important is that we don't need to go to the iliac crest to take cancerous bone. If you want a cancerous bone, and you can take it from the vertebral body adjacent to that site and very minimal, that is good enough, because the cancerous bone have all the three properties: osteogenicity, osteoconductivity, and osteoinductivity. So they are the best ever available. So when you mix that with our the fusion site, the fusion is very fast. And the same thing was published in the Journal of Spinal Surgery in India. So we have published 2 techniques and this one. And we are very happy with this technique. And I am very happy to share this with all of you. And I also thank all of you for giving me this opportunity. Dr. Nargisa, I'm very happy. And also my panelists, I hope that you all enjoyed my talk. Thank you very much.
Thank you very much for interesting talk. Yes, I never seen before the technique you were talking today, and yeah, it's important to use it, I think. We have one question from the audience. Sir, sometimes it becomes difficult to differentiate between post-annulus PLL and seems scary whether it is whether to lift or it is a dura. So how to differentiate dura or the PLL?
Yeah. See, one thing I would like to make it very clear: the color of dura is totally different. The color of dura is more or less, whitish, grayish, and mild. The PLL is always tough. The PLL is a little tough, but never the dura. So that's why if you carefully look at the hooks which I was using, I use 3 type of hooks. One is a sharp one is a blunt one. So you have to use these hooks alternatively in sequential manner. Once you get the hard one, that is the PLL is as a long fiber. It's a long fiber. So you can always hook it like this, right? So the PLL is not only is a thin layer, it is a thick layer. So you can hook it, and once you hook it, lift it, that means that you are with the PLL. Dura cannot be done like that. Once you lift it, you don't need to worry about it. I really appreciate the candidate who asked this question, because this is what I said, the scare of doing how I'm going to. But if you hook it up, you know that you can differentiate between the dura and the PLL. And after that, I usually take with the hook itself, I tear the PLL. You don't need a 11-blade knife. Some surgeons use the 11-blade knife to cut it. But if you don't have a good technical skill, then you may damage the dura. So best thing is you take the hook and hook it out. Then after that, you get a gap between the PLL and the dura. Put 1 mm kerrison, and then cut and remove the PLL. You can do these things only when you remove the osteophyte and the fibrous annulus, that complex. You saw the technique, complete my technique. And if you repeatedly see these videos, and then you can easily do it. So I advise the young men and to carefully do the dissection at that place. No problem. No need to worry about it.
Thank you.
Thanks, Study. Let me, excuse me, let me just interject. We have a question from Mohammed Shoab. Do you want to ask the question, Mohammed, or you want me to ask it? Can you read it? Can you read it?
Mohammed, you can.
Nafisa?
Hi.
Oh, there he is. Go ahead. Go ahead.
Hello, sir. Good afternoon. Very nice presentation. Thank you very much. So one thing I wanted to ask is, you already clarified regarding the PLL and how to differentiate it from dura. That is where I usually feel scared, or like whether I'll be damaging a dura or not. One more thing is, while starting the procedure, after you have dissected platysma and you have found out anterior border of sternocleidomastoid, So sometimes it is difficult to find a plane, and even there it is a bit scary because the carotid is just beneath your finger, and sometimes the dissection can take you laterally also. So how do you proceed with that, sir? Well, for a
Okay.
young neurosurgeon like
Yes,
me.
yes. I really like it. See, I tell you very small points. You know the fascia is there. Once
Sir.
you take the sternocleidomastoid medial border, right? When you take the medial
Sure.
border, just lift it. Just lift the with a force of sternocleidomastoid and cut that fascia medially, medial to the SM and dissect it. Dissect it,
Sure.
you find the cleavage is going down. Okay, so that fascia has to be the first fascia you have to open it.
Okay.
After that, take a Langenberg. And in fact, that I have a presentation, but I don't have time. Nargisi has given me only 15 minutes time. So you take the Langenberg, small Langenberg, and maybe ask your assistant to retract the trachea and esophagus medially. When you do that, you find the fascia is stretching. All right.
Okay.
You put your left finger underneath the SM, sternocleidomastoid, now down, like this, here, and you find the carotids palpating, right?
Sir.
And you use your dissection medial to that.
Sir. Okay.
The same way you send the Langenberg down.
Okay.
And then do it with, if you wanted to do the fascia, do with the peanuts.
Okay.
Okay? The cotton,
Sir.
the cotton, you make it,
got it.
ask your nurse to make it different sizes and shape, and don't make it to tangle.
Sir.
Hold it at the distal end so that you have enough cotton and the gauze to scrape the
Scrape out.
fascia. You will get it. You have to be very patient. You will get it. Nothing will happen. And once you get the free areolar tissue, then you negotiate the Langenberg further.
Okay. Okay. Thank you very much, sir. Thank you very much.
Similarly, that is the first fascia. Then you get another fascia at the carotids, medial to the carotid. You open that, same fascia. Then you get the last one, that is the prevertebral fascia. So three fascias you have to cut.
Sir, thank you very much, sir. Thank you, sir.
Yeah, let me just mention that Mohammed works with Ashton Tandon. He's a minimally invasive spine person. We're going to have some webcasts. I'm going to suggest you, Jody, as the guest for him.
Yep.
Perhaps you know him. Do you know Ashton Tandon?
Currently, I'm working with Dr. Ashish Tandon in Jabalpur, sir. I'm his fellow.
Good. Mohammed.
Okay, Nargiza.
Okay, so we can move to our third speaker, international speaker, Dr. Maria Ganao, MD, PhD, FRCS, Edinburgh, FACS, consultant neurosurgeon and spine surgeon in Oxford University Hospitals, National Health Services, Oxford, United Kingdom. Dr. Maria Ganao is the member of EANS. He is part of the committee, and today Dr. Mario will be talking about microdecompressive lumbar laminectomy in segmental stenosis associated with Meyerding grade 1 listhesis. Welcome, Dr. Mario.
Hey, Mario, you're muted. I think you're muted.
Do you unmute yourself, please?
Mario, can you hear us?
Dr. Mario? Yeah, okay. 1 second.
There you go.
Tell me if you can see my screen.
Yes.
And,
not yet. You fell off.
Okay.
There you go.
Yes, now we can see the screen.
Okay, and then let me see how I can.
Yeah, it's usually at the bottom. Presentation view, presenter view. They're perfect, perfect.
Is it good?
Yes,
Yeah,
it's good.
Perfect. Look,
I-
it's a bit of technical issues for me. Thank you very much, Nargisa. Thank you, John. It's a pleasure to be here with you this Sunday. Yes, I'm a consultant neurosurgeon, Oxford University Hospital, and honorary senior clinical lecturer at the University of Oxford. I'm educational officer for AO Spine Council UK and Ireland. I do not have any conflict of interest related to this talk, and I'm going to present on surgical technique that is should be, I believe, in the armamentarium of any neurosurgeon. So the topic is management of lumbar canal stenosis. As you know, the default technique for this type of pathological condition is a wide laminectomy. However, this might lead to the destruction or insufficiency of pars interarticularis and facet joints. And certainly the open technique requires a prolonged retraction of paraspinal tissues. As a result, there is a possible need for concomitant or subsequent fusion. There are a number of good articles on this topic, Hope et al., but certainly Gogawala and the Sleep Investigators, which was published in New England Journal of Medicine in 2016, comparing fusion versus non-fusion for lumbar canal stenosis in the context of spondylolisthesis. The prolonged muscle retraction, as we know, may be responsible for a high rate of perioperative pain, might be the source of a failed back syndrome. And we all see a lot of patients in our clinics with a lot of fat infiltration in the paraspinal muscles, and this might be itself the source of persistent back pain despite adequate decompression. The limits of the wide laminectomy is that obviously in elderly patient, you might have poor bone quality. If there is a spondylolisthesis, removing the posterior elements might increase the degree of spinal instability. In patient with scoliosis, obviously, you would be concerned of performing a lumbar decompression, because this might in itself cause additional deformity of the spine, both in AP and lateral sections. And then obviously many patients might have other comorbidities like osteoporosis, lupus erythematosus, or rheumatoid arthritis that might be responsible for very poor baseline and might affect clinical outcome. The microdecompressive laminotomy is a very elegant surgical technique. Usually is done, as I say, under microscopic vision. Consists on the excision of the ligamentum flavum and the undercutting of the lower portion of the upper lamina and the upper portion of the lower lamina. And by doing this, basically, we can have unilateral or bilateral access to the spinal canal. And that's the reason why in recent years, this surgical technique has more and more been considered as an over-the-top decompression. And over-the-top is used as a synonym of microdecompressive laminotomy. This is suitable for central and lateral lumbar canal stenosis. And I put here a snapshot from the famous article published in Journal Neurosurgery Spine by Claudius Tomé, the head of the neurosurgical department in Innsbruck, and who basically popularized this approach. However, it is quite unclear whether this microdecompressive laminotomy can be safely used in any patient or not. And this is the reason why we had a good research question for the prospective study that I'm going to present. So we included 2020 patients, and out of those 2020 patients, we identified a subgroup with Meyer-Dean grade 1 spondylolisthesis, and we compared these 43 cases versus the 177 controls. The endpoint of the study was to assess the symptomatic relief, increase in the spinal canal diameters following this type of laminotomy, and the functional improvement of patient at short and long-term follow-up. I conducted this study during my neurosurgical training, and obviously these justify why the follow-up for the patients is so long. Also increase the internal validity of the study. In terms of the methodology, we perform a quantitative and qualitative assessment of those patients. At the very beginning, we calculated the visual analog scale and Beaujon scoring system. Visual analog scale is very unspecific, as you may know, but the Beaujon scoring system is tailored around the needs of patients with lumbar pathologies. It calculates the degree of neurogenic claudication, the degree of lumbar canal, degree of pain due to lumbar canal stenosis, both in terms of low back pain and in terms of radicular pain. And it also assesses the satisfaction of patient with the quality of life. So it can be used both pre and post-operatively. The radiographic assessment was done with CT scan and MRI scan so that we could calculate in both type of modality, knowing that the CT scan is a better imaging for bony structure, whereas MRI scan is much superior in terms of studying soft tissues. And then we did, as I say, a short and long-term outcome analysis by using the McNabb criteria. McNabb was a very skilled Scottish surgeon who made a name for himself when he moved to the University of Toronto. And those McNabb criteria are important for anyone with an interest in lumbar pathologies. From my point of view, having done my fellowship in spine and trauma at the University of Toronto, I'm particularly proud of that. So let's go to the clinical and radiological outcomes. We had 220 patients. As I say, the male-female ratio was 4 to 5. 65% of those patients were older than 65 years. So I think is a study that, although did not reach a statistical significance for the age, certainly gives a very good overview of the management of lumbar canal stenosis in the elderly. 29% of patients had comorbidities such as osteoporosis, lupus erythematosus, or rheumatoid arthritis. 50% of those patients had degenerative scoliosis with a Cobb angle superior than 20 degrees. So here are some intraoperative images. As you can see on the images on the upper left corner, unilateral approach showing a very nice decompression of the thecal sac. You can see the root going through the lateral foramina. And basically, this is an overtop decompression because through this small approach, we were able to decompress also the contralateral nerve root. When the lateral stenosis is extremely severe, then we might want to use a bilateral laminotomy, because this will facilitate also the foraminotomy, which otherwise might be a little difficult through a unilateral approach. And you can see a very nice image of a bilateral laminotomy in the lower right corner. This is an intraoperative image of a multi-level laminotomy, and you can see the 3D reconstruction nicely showing that basically you can tailor the extent of the laminotomy to the type of narrowing that you might encounter on the segmental stenosis. This 3D reconstruction really gives a very nice understanding of how it is possible to create an over-the-top decompression, undermining the contralateral lamina, undermining basically the base of the spinous process, removing all the ligaments and creating all the space that the thecal sac needs. In terms of clinical assessment, as you can see, VAS score significantly decreased in both the case and controls after surgery, and the Beaujon scoring system increased, showing a better functional outcome following the compressive laminotomy, and the results are statistical significant. Here are a few axial views on CT scan, just to show you how we did perform the AP interarticular and transpedicular measurements, and just a few cases. So here you can see a patient with a multi-level lumbar canal stenosis with grade 1 listhesis, and this is caused by multiple degenerative changes in the spine, including obviously a thick yellow ligament and obviously the dehydration of the disc with part of the compression coming from the front. And this is the result post-op. Unilateral approach coming from the right, because this was the side where the patient was mostly symptomatic. And then you can see on sagittal view how the unilateral approach was able to create a very good central decompression. The axial views at the bottom of the screen really give you the sense of the extent of this decompression. The thecal sac is fully decompressed and takes all the space that it needs. And I put this view to show you how we did not have any case of spinal instability, a long-term follow-up. So you have listhesis L5S1. This is borderline between grade 1 and grade 2 Meyerding scale. And you can see in the image on the right a very nice central canal decompression and no changes in the listhesis after surgery. And this is a table showing you the statistically significant results in terms of increase of the diameters, both on MRI and CT scan. And I want to focus your attention on the figures at the bottom of the screen. Preoperatively, the axial MRI area available for the thecal sac nerve root was only 48 millimeters square, whereas in the postoperative view, we increased this to 148 millimeters square on average. So this means that the increase of the axial of the space on the axial plane was more than threefold. It's an amazing decompression. All the calculation that I show you, AP, intraarticular, and transpedicular, are according to the Amanishi technique, Japanese surgeon who basically standardized this type of measurements. And I think they have a very good external validity because you can replicate in all your cases. And it would be nice also to use those type of calculation when you write the follow-up clinic letter for your patients, so they can really get the sense of the degree and the extent of the compression. And here I want to show you the results in terms of McNapp criteria. As you can see, 146 patients out of 220 achieve a grade 1, which means excellent. And then in fairness, we had some cases with a fair or poor outcome, 7 with fair, 3 with poor outcome. And obviously, it's very sad to see some patients that do not improve despite a satisfactory decompression. I think this tells a lot about the impact of comorbidities and the fact that failed back syndrome might be something that, despite a good surgical indication, we might never be able to reduce to 0. So my final remarks, microdecompressive laminotomy allows for immediate pain relief and rapid post-op mobilization, satisfactory long-term outcomes despite very few patients, 3 with still poor outcome out of 220. Because of the advantages of the laminotomy, including fusion avoidance, this technique should be particularly recommended instead of more invasive ones in patients with fragility of the spine. I'm showing you a few articles that basically are showing very similar results, or anyway are in keeping with our conclusions, particularly this one from Sasai from Journal of Neurosurgery. And if I can go back 1 second. Yes, the limitation of the study. This is something that we always should consider. I think one of the issues is that this was a single center prospective study without any randomization, and obviously this might decrease the external generalizability of the result. But from my point of view, and this is mostly related to the fact that yes, we included patients that were operated many years ago. As I said, this was part of my research project during my neurosurgical training at the University of Verona. Obviously, back then we had only few cases done with microtubular retractors. Exoscope was not invented. Endoscopy was not in the armamentarium of surgeons. The patients were included between 2004 and 2010. Follow-up reached 2013-14. So obviously, in the last 10 years, neurosurgery has made some progresses. And I think although the laminotomy is still a very popular procedure and done almost on a weekly basis in our department here in Oxford, I think the management of a patient with lumbar canal stenosis and spondylolisthesis also warrants consideration for other technique, as I say, exoscope or endoscopic surgery. Another limitation of the study is that I considered only patient-reported outcome measures like VAS, Beaujon scoring system, and McNabb. However, I did not calculate the minimally clinically important difference, and within the EO spine community, particularly those like me that are involved in the EO spine knowledge forums, calculating MCID is key because it provides an extra layer of accuracy in understanding how those surgical technique impact the quality of life of our patients. So let me move to, yes, just to say this study was extensively presented on the AANS and CNS meetings. Always receive a very good comments and feedbacks from the attendees, and I really believe that should remain in the options considered for our patients. Here in Oxford, we do it all the time, and this is just to say that we try to move forward. This is a post on Twitter from 2019. Apparently, I was the first one in the UK to use the exoscope to perform this type of decompression at L3, L5 for lumbar canal stenosis. My colleague here in Oxford are heavily involved in the development of endoscopic spine surgery, and this is the same in the Thames Valley spine network. Our colleagues in Milton Keynes are moving forward into that direction as well. And I really believe that endoscopic surgery might be the future and a way to further decrease the invasiveness of this type of decompression of thecal sac and nerve roots. With this, I thank you all very much for the opportunity to discuss this prospective study here in the Russia Neurosurgery Grand Rounds. I conclude, and I thank you all for the attention. I'm open to questions if you have any.
Thank you very much, Dr. Mario. It's interesting, nice presentation, and I never knew that you have done a spinal case under exoscope back in 2019. Very good to know. I also do believe that the future is lies under exoscope as well.
Mm-hmm.
So we have just one comment from Nikolaos Sirmos, who said, "Great presentation by Dr. Mario, as always." So probably he knows you. Any questions or
May I
comments?
say something?
Oh, Dr. Nikos, good afternoon.
Go ahead, Nick.
If you have
Hello,
questions.
hello,
Yes,
Hi,
hello.
Nick. Go
hello,
ahead.
everybody.
Go ahead, Nick.
Hello, everybody. I'm Nikolaos Sirmos from Thessaloniki, Greece. I want just to make my compliments to my dearest friend, Dr. Ganau, as we are sharing together our neurosurgical experience from the last 20 years. This is a marvelous technique performed by Mario, and it's very important because spinal stenosis, it is a phenomenon that will cover all the European population in the next 20, 30, or 40 years, because as the European population is getting older and older. Mario compliments, and I wish you to perform a big series, the biggest European series, and I will be grateful to help you.
Thank you, Nikolaos.
Also compliments to the Russia ground rounds of neurosurgery, because you select very well all the speakers, and it is a very important and very interesting webinar.
Thank you so much. Thank you. Any other comments, maybe, Dr.
Yeah. Hello.
Yes.
Yeah, I have one question. First of all, very nice presentation. Thank you very much. If after this procedure, if the patient comes for follow-up, and if there is progression with the listhesis, how would you proceed with it? And if the patient has some pain relief, but there is progression with the list?
Yes. So in these 220 cases, we did not have any case of progression of the listhesis. However, I had some other patients where, as opposed to a laminotomy, the surgical procedure required a unilateral laminectomy, which is slightly different because then you remove the entire unilateral lamina. In those patients, I have seen progression of the listhesis. Despite that, some were managed conservatively because the radiological worsening was not associated with a clinical worsening. In other patients, we had opted simply to perform instrumented fusion, and because the unilateral laminectomy allowed you to then work a little bit laterally and do insertion of a T-leaf, it was easy to just reconstruct the anterior column with the T-leaf and then pedicle screws on the lateral fixation.
Yeah, thank you very much, sir. Thank you.
Thank you. Any other comments or questions? Or should we move to our last speaker for today?
Thank you so much.
Thank you, Dr. Madhav. Dr. Bulat, you are here, right? So I can present you.
Yeah, I'm here.
Okay. Our last speaker for today is Dr. Bulat Kinziagulov, MD, young neurosurgeon from Russia, from Pirogov team. Dr. Bulat is consultant neurosurgeon of Neurosurgical Department of National Medical and Surgical Center, named after Pirogov from Moscow. And today he will be talking about low-grade ischemic spondylolisthesis, factors affecting outcomes. Please, Dr. Bulat. Welcome. You can share your screen. Yes, we can see your screen.
Can you see my screen? Yeah. Hello, everyone. Once again, thanks for the invitation, for this opportunity to sit here and tell you about one of my favorite subjects in the neurosurgery, about
Excuse me, could you put it on presentation mode, please? It's one of the bottom options there at the very bottom.
Yes,
there you
right.
go. Perfect.
Yes. Okay. Firstly, let's take a look at the plan, today's plan. I will try to explain what is the ischemic spondylolisthesis. I think it would be very important for all the students, residents, and young neurosurgeons. Of course, we'll talk about main questions and historical perspective of surgical treatment of ischemic spondylolisthesis, and then we will talk about radiological and functional outcome of patients and discuss whether we need or not need to reduce in operative treatment. Ischemic spondylolisthesis is anterior translational one vertebra relative to the next caudal or vertebra below because of the defect in pars interarticularis. What is the pars interarticularis? please, you're watching this illustration, and it is a part of vertebra between superior and inferior facet, where we can see the defect in cases of ischemic spondylolisthesis. So after that, we can observe spondylolisthesis there. Well, who are the patients? There are many studies in which authors tell us about prevalence of ischemic spondylolisthesis cases among athletes like gymnasts, hockey players, wrestlers, and so on. So we can confidentially say about traumatic etiology, chronic stress loads on posterior part of vertebrae, and so on. But at the same time, there are lots of family cases of ischemic spondylolisthesis. And now you can see on the screen the child from Inuit tribe from Alaska, where the incidence of pars defect is about 18%. So I think they do not try to do gymnastics there. It's not about this. So we can say about the multifactorial etiology of this disease. We don't know real incidence of ischemic spondylolisthesis, but our colleagues from Japan in recent studies stated that it can be up to 18% of general population. And when we meet the patient with ischemic spondylolisthesis, we have several options, of course. First of all, we try to prescribe conservative treatment that can include myorelaxants, non-steroidal anti-inflammatory drugs, and of course, physical therapy. But in some cases, when patients can't tolerate the physical therapy, medications remain ineffective. We have to do surgery. It's about 15 or 30% of cases. What can we do when it occurs in children? Many studies from the past reported about very good and excellent outcomes after repairing the defect. But what if we follow the wait and watch tactics? Recently, many researchers reported that nearly 94% of cases accuse the bone healing of the defect. Moreover, Dr. Choi reported that 94% of his patients came back to sports, and only one patient was operated. And one more research where authors say that 90% of spondylolysis patients aged more than 60 years showed spondylolisthesis. None of the patients with ischemic spondylolisthesis had received fusion surgery, suggesting that most of these patients didn't have a severe disability requiring surgical treatment. Let's look at the history of surgical treatment. In the 70s, surgery included posterior spondylolisthesis without any instrumentation. And only in rare cases, surgeons performed interbody fusion with bone grafting. The main question at that time was about necessity of posterior instrumentation. Then in the 90s, most surgeries contained of posterior instrumentation, but more and more surgeons kept wondering if they need or don't need to do fusion and reduction. Nowadays, posterior instrumentation and interbody fusion is the gold standard of surgical treatment, but necessity of vertebrae reduction remains controversial. Moreover, what do we know about outcomes after surgery? We can divide outcomes into two main groups. First of all, bone block formation in operated segment. Second, functional or clinical outcome. Of course, all of us want to have a really good, perfect radiography immediately after operation and 12, 24 months after operation. But most of our patients with ischemic spondylolisthesis are quite young. Many of them do sports, and it's crucially for patients to come back to their daily activities, I think. First of all, fusion rate. There's lack of high-quality evidence on fusion rate in patients with ischemic spondylolisthesis in literature, but we have found a meta-analysis and systematic review on fusion rate in the degenerative spine diseases. Here, authors stated that it really doesn't matter which approach for interbody fusion do you use. Airlift, 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 it's all the same. Also, they reported about 89% of fusion rate using bone autograft and 94% with bone morphogenetic protein. They stated that the material of the cage don't affect the fusion rate. And researchers found that age, osteoporosis, smoking, obesity can significantly impact the fusion rate. Many articles compared different approaches, the form of the cages, but didn't assess factors, unfortunately. So, to answer many questions, we decided to perform our own research. We assessed bone block formation via Christensen scale in CT scans 12 months following up the surgery. The first two grades means that there is probably fusion or completely fused vertebrae. And the other three grades showed us the absence of fusion, or even the fifth grade, we can see pseudarthrosis features. Characteristics of our group are on the slide. Pay attention to the median age of patients. It is 48 years. So, as I've mentioned earlier, patients with ischemic spondylolisthesis are quite young. Without going into details of statistical analysis, we can say that obesity and long-term usage of non-steroidal anti-inflammatory drugs after surgery can significantly impact on fusion rate. Long-term means here 3 months and more. In the second group of factors, we didn't find any significant ones. Yeah. We have made 2 regression models. The first included obesity and non-steroidal anti-inflammatory drugs with long-term usage. And in the second one, the same plus smoking. As you can see on the slide, both of them prove significant statistical significance. But there are some coefficients that showed us significance of smoking too. And what about functional outcome? Only one systematic review from 2018 showed that fusion plus instrumentation plus posterior spondylolisthesis is better than instrumentation plus posterior spondylolisthesis alone. And again, doesn't matter which approach do you use. Unfortunately, because of the lack of research, it is only low evidence. Recent studies confirm those statements. Once again, interbody fusion and posterior instrumentation is a good choice for ischemic spondylolisthesis cases. And doesn't matter which approach do you use. One more study, one more research. Here, authors assessed 39 factors and found only correlation between leg pain, working stages, and outcome. Let's take a look at our research of factors affecting the outcome. We assess 2 main groups of factors, not connected and connected with surgery. And not modifiable factors like gender and functional stages before operation, and modifiable obesity and smoking. Average age was the same as the previous study. Median ODI before surgery was 33 and after 4. After statistical analysis, we found that obesity can significantly impact the functional outcome. Moreover, psoas cross-sectional area was in inverse proportion to ODI score after operation. It means the simple rule: good musculature, good outcome. Let's go to the reduction. One meta-analysis reported that it has a significant influence on bone block formation, and authors found impact on functional outcome. Unfortunately, researchers do not divide low and high grade ischemic spondylolisthesis. But we think low and high grade spondylolisthesis cases are really different, nearly different pathologies at all. In our presented studies, we have found no influence of reduction on fusion rate and clinical outcome in patients with low-grade ischemic spondylolisthesis. And what are the modern trends of ischemic spondylolisthesis surgery? In recent years, endoscopic TLIF gains popularity, so who knows, maybe it will help to improve outcomes. Thanks for your attention. Take-home messages on the screen. I hope it will be helpful. Thank you, Dr. Bennett, once again, for Nargiza, for the invitation, for this opportunity. Thank you very much.
Well, thank you very much for your nice presentation and all take-home messages which we will put. Yes, finally, after so long time, I invited Dr. Bulat for the talk, and the talk was perfect. Thank you, from young neurosurgeon.
Thank you.
Anybody has questions or comments from the audience? Mohammed, would you like to tell something? Mohammed said that that was great presentation. Thank you.
Thank you, Mohammed. Thank you.
Okay, probably.
Hey,
Dr.
don't be
Patel.
shy. Don't be shy. This is a chance to
Comments?
talk to the source.
Dr. Partiban, would you like to give any comments maybe?
Yeah, it's a very nice talk by Bulat, and it is always a controversy, as he has made one slide fantastic, the slide that he showed the history. Because the history, the period is absolutely right in what was done earlier and what is now. And the dilemmas was initially because there were no techniques, there were only wiring techniques were there. So it was only decompression was done, and you take the bone and keep it on the side, posterolaterally close it. Okay, that was the, and then you put the patient for 1.5 months on bed rest.
Yes.
With a cast. Okay, that was the technique in 1990s and 80s, 90s. The 90s slightly became better, and then when start getting the pedicle screws, then the system came that okay, why don't we try to fix it? And then at the same time, when the interbody fusion came, that time there is no TLIF, no TLIF, PLIF.
PLIF.
For interbody fusion. So for L5 and S1, PLIF was much easier with pedicle screw fixation. But for L4 and L5, it is always difficult if you have a very narrow lateral canal, because your postoperative complications with the foot drop was very high. So the seasonal development towards the interbody fusion, as he rightly pointed out, the first thing is whether you need to fuse it or not, or you need to fix it or not for the low grade spondylo. The least that's about 25 degrees, up to 25 degrees percentage. So whether it is needed was in question, but subsequently now, as he said about interbody fusion. So we are going towards a period where interbody fusion can help much better in a long-term fusion is concerned. I personally feel that it is going to be a debate of concern. And the points which you made about the obesity, smoking, and osteoporosis, and they are going to be more challenging because those patients have low fusion rate, and so they need a fixation, and so they need fusion, right? So in those patients, attempting the surgery itself is a bit difficult. But once you attempt it, then you have to fix it and also fuse it. And there was no choice. You have no choice in this. So generally, I like your talk very much. It was very nice and very useful, Dr. Bulat.
Thank you, Dr. Patiban. Thank you very much.
Yeah.
you. Anybody else who wants to give comments? Actually, I like today's webinar so much. It was so cozy and nice. And finally, we came to that point when we can do just special narrow field section like spinal, functional. Next year, I'm planning to organize some functional neurosurgical webinar. So it's good when we have expertise like Dr. Parthiban who can give these tips and tricks how to operate, how to go. So me myself, I was trained in spinal surgery in India. So whatever techniques you were telling, I was using them as well with Dr. Sajeev Vadakidam from Kerala. So I used to assist a lot on ACDF. Thank
Yeah,
you.
I'd like to say thank you for all the speakers for speaking. Thank you for arranging everything, Nargiza. And you'll be seeing Jari, probably Ashish Tandon, a neurosurgeon from India, who Mohammed works with, is going to have a webcast on minimally invasive spine. So he'll probably be inviting you guys to do that. Other than that, we look forward to our next Russian neurosurgery grand rounds. And thank you, Mario, for coming from the British Isles. Okay, and we'll be seeing you in 2 weeks, right, Nargiza? Is it 2 weeks, Nargiza, or
Yes, 17th of December. We are planning to do the last webinar this year, which is
Okay.
going on. We'll be talking about approaches, and that will be neuro-oncology mostly. So I already have 3 speakers, so I have to find another 2.
Okay, it's good to have Russia in the orbit of the network. And we'll see you in 2 weeks. Thank you
Yes.
very much. Stick around, stick around.